Thank you. Good morning. Confession. I was a board member of a large hospital organization in Seattle. QIO was just another acronym. I didn't know what you did being a board member for 12 years. And I'm sure the same occurs across the country. I took my confession to our local Qualis group, and Jonathan gave me a couple of hours to share with me what you do. So you can thank Jonathan for having 5 slides versus 55. You can thank Jonathan for no graphics and no ask to get from 98.5 to 98.6. And I understand the most important part is that there's not going to be a pass or a fail test at the end of this particular discussion. So Jonathan, thank you very much. Saving lives from the boardroom. Who is the boardroom? Why is the boardroom so critical? What can the boardroom do, and only the boardroom do? How can you ignite, and also use the D word, demand that the boards get engaged in patient safety? By when? Don says now is not a time. I agree. So I would suggest the next 10th and or a subnational project, which is a term I just learned in the last couple of weeks. So why am I really here? I'm here to go over this program with you, but I'm here because when I was a CEO in the maritime business, on my watch, we lost a sailor overboard, 25-foot seas. We couldn't recover him because we didn't have the gear on board to do so. On my watch, when I was a board chair, we lost Mary McClinton, a patient who had checked into Virginia Mason, expected to leave the organization, and had a tragic death due to medical preventable error. I'm here because I'm a father, and our daughter at 4 was misdiagnosed as having the flu when she actually had E. coli. We finally got her to the right hospital within 24 hours of renal failure. And I'm here because my wife and I had a very tragic handoff with our same daughter, who was 6 years old. We were fishing in Alaska, had just got back to the dock. I stayed on the boat. Jan took my daughter off the boat. I thought she was going up to the lodge, took her life jacket off. I was on the boat working. I heard this noise. The boat moved a little bit. Walked over to the side of the boat, and all I could see was my daughter's blonde hair streaming up through the water. Fortunately, she had long hair. I was able to reach down and grab her and bring her back up. Those sorts of near misses occur all the time in our hospitals, and they're tragic to the patients. They're tragic to the caregivers. And I can only think about our caregivers in our organizations when I think about how Jan and I almost failed our daughter in terms of the handoff. So I'm here because I'm passionate about safety. I'd like you to picture a typical boardroom. Board chair, officers on one side, typically the CEO and his officers on the other. Maybe one of the CEO's managers is in there to present. Starts with financials, run out of time to talk about safety and quality. I'd like to visualize an engaged boardroom where there's clear governance and operational responsibilities. When I was a CEO, I knew that I had operational responsibilities for safety, and the board held me accountable. I learned about governance responsibilities very early in my career. We were selling the company. I had just become CEO. We went through 30 presentations, profit, balance sheet, income statement, market shares. An investor group walked in about 2/3 of the way through 30 different presentations and said, we've seen your data. What I really want to know is if my son and daughter work for you, sail on your vessels, work in your shipyard, how would you feel about that? Would you feel safe about them working in your organization? That's governance responsibility for safety. And if we had all of our board members thinking about that, we would have a much better place for patient safety in our organizations. Why is the boardroom so important? The boardroom is responsible. We have governance duties of obedience, loyalty, and care. We have ethical responsibilities for patient safety and staff satisfaction. The boardroom is in control. The boardroom develops mission, sets strategies, should set goals and objectives for safety and quality, selects management, and provides the resources, both dollars as well as the human resources, if we are going to go through safety and quality improvement. And the boardroom has the power, fortunately or unfortunately. The boardroom can make anything happen, particularly with respect to patient safety, or through lack of inaction or specific actions not to support patient safety. Both of those can be deadly, quite literally, deadly to patient safety. The buck stops at the board. The board is overall responsible for patient safety. What can the board do? Many, many things the board can do. If you're walking down a beach, pick up the bottle, genie pops out, what are 3 things that you can do to improve patient safety by getting the board engagement? I would suggest to you that they are getting the board to assess their own current patient safety position, put a face on the statistical data, and take ownership for patient safety. Even the best of the board documents in terms of patient safety get old over time. I remember when we said, it's been a couple of years since we really dived down on our safety statistics, let's do that. We did it in a retreat. It was phenomenal. We got each of the board members to say, why are we tracking this? What's our trend been? Who are the best performers? Why are we where we are? What are the best performers? And if we're getting better by only 5%, how many more patients, real patients, does that mean that we're harming? If we can get the boards just to do that, we can save hundreds of lives in this country. The next thing you need to do is put a face on the statistical data. You see all the graphs, you see all the numbers, you see the dots. Put a face on the data. And the way I would suggest you do that, work very well for us, is bring a patient into the boardroom and take the boardroom to the patient. First time we brought a patient in, it was a feel-good story, and that was okay. We'd allocated 15 minutes at the start of the board meeting. After about 2 good feel stories, I sat down with our CEO and I said, look, there's other things going on in the organization. Let's challenge ourselves. First story that came in, challenging story in terms of patient safety, told very well by the patient and the caregiver, our own caregiver. We spent an hour talking to the patient, talking to the caregiver, and talking about what had happened and how we can ensure it doesn't happen again in the future. Get the boardroom out to where the work is done, to the bedside. Have the boardroom round with your senior executives. No major agenda, just get out and be seen that you have board members and they're responsible. It's huge. And I think the third one that's probably most important is to take ownership for patient safety. We thought that we were doing very well in terms of communicating that the board backed management with respect to transparency, our vision of becoming a quality leader. We lost Mary McClinton, who presented herself to our organization, and we failed her. We failed her caregivers. We brought all the employees into a room about 2 weeks later, a room about half this size, 5,000 employees in total. And I got up alongside our CEO, and we both said, no more harm. We're committed to no more harm in this organization. We had a patient safety alert system at the time that was producing about 100 safety alerts a month. We knew it wasn't nearly what was going on. After Mary's death, after we got up and the board said no more harm, and we support transparency in the organization, the next month we had 350 patient safety alerts. And that number stayed at that number for the next couple of years. Now you say, why doesn't it start to go down? Because there's that many things going on in healthcare that are alerts that we need to pay attention to. We celebrate Mary's life each year at Virginia Mason by bringing in Mary's family, and we reward the employees in the organization who've done the most in their departments to improve patient safety. And those awards are given out during the celebration. There's not a dry eye in the house because of the loss of Mary's life, but also because we know that we are making a difference in patients who are presenting themselves on an ongoing basis at Virginia Mason. So take ownership would be the third, probably the most powerful thing that the board could do. So what can you do here in terms of this mission? You can make the boardroom engagement a priority. 10th scope of work, subnational project, whatever the terminology is, make the board a focus point going forward. There are many, many tools that can be provided to the board to get them going, to help them challenge their own status quo, to demonstrate that they have accountability, to help them assess their current performance, inspire change by showing stories of who have gone before them. And what I think is going to be very powerful is we're producing a portal that will have a buffet line of governance best practices that organizations can go to and say, you know, this one fits for me. This is something I can run with. As a change vehicle, think about a boardroom certification program. Very simple. It could start out as just having the boardroom certify that quarterly they look in depth at their statistical accident rates. It doesn't matter which ones they are, it matters that they are looking at them. So boards are made up of good people, bad processes. You've heard that before. Boards want to do good. They don't always know what to do. You're in a position to help them. We can help you with the tools. A great start is to get the video that you have before you into the hands of the provider organizations that you are out there in contact with. That would be a great first start. All we have to have is one boardroom, one life at a time, and there are thousands of lives that can be saved. Thank you. Next speaker is Dr. David Pryor, who is Chief Medical Officer of Ascension Health.